it was really exciting also for me to know all these new kind of things, but still the patients are dying, and this is an aspect that we as clinicians are very concerned. So one possibility I will show you is really to transplant them. We have heard already that's a real problem in Brazil, this disease. I will not bore you with this again. It's very frequent in Brazil. And what is interesting is that in the last, certainly in the last 25 years, we have not really improved survival of this patient. So this is a concern when you are a clinician. And this is data from the US, certainly underestimated because probably some of the patients died of pneumonia and it was not written that they have sickle cell anemia. And if you look, these different time points really have not improved overall survival of these patients. What we indeed have improved was survival of the kids, but certainly not of adults. And this is something we really have to improve. One important aspect, and it was already shown, is to identify really some kind of risk factors just for us to know who will be the patient who will have a worse outcome and a best outcome. And I know this Jacques Lyon is looking for that already for a long time. And it's very difficult to really to know who will be the kid who will have a stroke, will have some really severe complication. We have nowadays only transcranial Doppler where we can really prevent early these complications. So that's why we still perform stem cell transplant in this so-called benign disease. I don't think it's really benign, but it's called by benign. And I will just show you the most recent data and probably the largest evaluation of stem cell transplant for sickle cell patients. This is a retrospective registry-based analysis. It's of the European stem cell transplant register and the US, and we are also here, Pure Ribeirão Preto here, together. And this was sent as an abstract to ASH this year. So we looked to all these registered cases, and it was almost 1,000 patients already transplanted in Brazil, in the world, half in the US and half in Europe. You can see that France has a huge collaboration, have a huge program here with François Bernardin, and they have probably the most experience in this field. As you can see, and this is something we know already of the transplant in patients with sickle cell, most of them transplanted are kids. You have to consider that all these kids had already some complication of the disease. So it's not a prophylactic treatment, but patients are transplanted because they have already some complications. And most of them are kids. We were also always afraid to transplant older patients, not only because their comorbidities, but I think transplanted based their assumption based on thalassemia patients, where we had really better results in kids. Most of them, most kids, patients, most of them already heavily transfused, half of them, most of them not in regular iron chelation. This is very different from thalassemia patients, so you have a really iron overload in these patients. And most of you see here are the most common indications. So this is the same all over the world. So these patients, I will stress again, had already several complications of the disease, and most of them are related. We have only few unrelated patients here. As you can show, we have a nice neutrophil and platelets engraftment, a little bit later for cord blood, as we know, always. And one concern, certainly when you use this kind of treatment, is a severe complication. This is graft versus host disease. And we are very happy to see that it's really not very common in this kind of patients. So this is a good, because you really don't need to have GVHD in these patients. Graft failure is a problem in this disease. They have a very active bone marrow, as you have seen. It's like thalassemia. Some patients underwent a second transplant, and unfortunately, we have some patients died. This is something not unexpected. But the overall survival in this large cohort of patients, as you can see, it's really very good. So it's something we can really offer for these patients. They are free of the disease after transplant. Most of them, as you see, this is overall survival and event-free survival. As I have told you, some of the patients lost the graft, but they don't die after losing the graft. In Brazil, we have a slightly different situation. Until 2003, we had only 6 patients. Although we have this number of sickle cell patients in Brazil, there were only 6 patients transplanted at the time in Brazil, all kids. And at the time, only 4 were alive. Already 2 died. And since most of the transplants are performed in the public system, it was a problem because the government don't recognize stem cell transplant as a treatment for sickle cell anemia. So the center stopped to transplant these patients. And so we decided to make a Brazilian project and try to convince the government that it could be that it should be included as a treatment. And we used certainly the indications already published by the European group. We just don't limited the age of the patients. And we decided to use only identical siblings and related cord blood because we know that the results with unrelated are not so good. So nowadays we have 39 patients transplanted in Brazil with a median age of 16 years. The indications are most the same as all the other cases. And as you can see, since the other centers stopped to transplant, most of the centers were transplanted, the patients were transplanted here in Ribeirão Preto. So let's focus on these patients. We have a slightly different cohort of patients. The median age is 18 years, so we have a slightly older cohort of patients. Most of them SS, but some as beta thalassemia. Several sickle cell trait donors. We know this is not a problem in this situation, and the indications are the same stroke, and we have just 1 patient in an early, it's what we like to transplant in the early situations. All other the patients were already very severe cases. As you can see, the survival curve is not very different from what was seen in the whole cohort from the US and the European data. We have 1 patient who died, unfortunately. It was a young girl with already moya. So she died 3 years after transplant with a hemorrhagic stroke. So it was a complications already from her disease that we could not revert with transplant. One interesting aspect is that, as you can see, the time they stay in hospital, it can be sometimes very long, but it's long not after transplant, it's long before transplant. So this is a little bit different from other situations, because this is something I really try to say to the other transplants. You have to prepare them very good for transplant. Otherwise, you have a lot of complications. Because the time of neutrophil engraftment and all this is not very different, but you really need to carefully prepare these patients for transplant. 2 specific problems, very important, the ulcers and the antibodies. And this is a patient we recently received for transplant. So certainly we have to, he has more than 10 years, this ulcer. He was treated with several treatments without success. And we are very happy that we have a collaboration with a dermatologist. And we perform a skin biopsy and grow these keratinocytes and fibroblasts for 6 weeks in culture. We took some blood from the patients and perform a fibrin glue, like a glue, and then it's make a spray of this glue on the cells, and then after cleaning the ulcer, it's covered with this fibrin glue and with the cells. And the patients, the first patient we performed, they went to transplant like that, so it stays open. It only closed with these cells and with this glue. And this was the patient. He had a very, very severe ulcer before transplant. And this was his ulcer when he came here. This was 1 week after keratinocytes, and this you can see the keratinocytes, they don't engraft, let's say that. They only cover the ulcer, and then they die. And this is on day 0 of stem cell transplant when he received the graft of the bladder. And as you can see, 24 days after transplant, when he was sent home, it was like that. And it really started to improve. And 6 months after transplant, it was absolutely closed. And he is now without immune suppression and without ulcer. Certainly, he has some signals of this long-standing ulcer, but he's really doing fine. So another really problem is, and probably in Brazil it's a problem, and we have really a very strong collaboration here with the blood center, because without this it would be really impossible. And these are 2 patients with several antibodies, very difficult to deal with these cases, and 1 patient with a transfusion block, so it was real indication for transplantation. And we performed several preparations before transplant. These patients stayed with us 1 month before transplant, in these patients all. And but fortunately, they are very fine now and doing fine. So what happened with these patients after transplant? Patient with stroke already. We had 3 seizures after transplant. We know the toxicity of cyclosporine, so this is something we really have to take care of the transplant. No patients had new strokes, but we cannot revert moya, and this we have seen in 2 patients. One, our patient that died 3 years after transplant, and we have 1 patient not transplanted by us, but in Belo Horizonte, and is now 10 years after transplant, but has still moya. So this you cannot revert. Our patient had already some pulmonary hypertension. She's absolutely normal, and the leg ulcers never opened. Fertility is a problem, certainly is a problem. We had 1 boy, he was convinced that he will never had a problem with his girlfriend, and so they tried it and made it, so he has his father. Female patients have gonadal dysfunction. We are very, very happy with this collaboration with the gynecologist. She are treating all these patients and are freezing this material to possibility them to have babies after transplant. So this is a very good program. And one thing very important for us certainly is quality of life. We have 2 fantastic psychologists in our center, and it's interesting to see that already 100 days after transplant, so 3 months after transplant, patients still are in Ribeirão Preto, are still taking a lot of medications, so they have all parameters except of the social part, because they are still here close, impressively improved. So it's something really, we know it from it's incredible to see how grateful these patients are not to having pain and not to having this disease. We have a group, it's a really incredible group, where we are studying other aspects, and so performing a lot of other studies involved in these patients, not only transplant but also not transplant, in looking for several different aspects of the disease before and after transplant. And as you can see here, we have several clinical projects looking of cytokines and endothelial markers, coagulation parameters during and before and after transplant, and clinical evaluation. This is Rafaela Malta. Karina Tosato, who is sitting here, she will be on this Cotutela program together with Elian Gluckman. We are looking on these HLA haplotypes. Our psychologists are developing this quality of life program after transplant. We have the collaboration with this gynecologist, Ana Carolina Japur, and Marco Andrei Cipriano, who treats the leg ulcers. And this program, François Bernardin will perform the same program in Paris too. So we are exchanging with her the protocol, and she will start to do it also in France. One aspect very important for us, we really don't know how is thymic function in these patients, not only after transplant, but in this patient there are no data. So Luciana Jarduli, where is she? Sitting there. She are looking on 5 different groups, so before and after transplant, using hydrea, chronic transfusion patients, patients in supportive treatment only, and most of them are siblings from the patients, so the controls, and she is looking, it's also a collaboration with a French group, with Antoine Toubert, on the thymic function. It's interesting that since we cannot really look in the literature because there are nothing described, but probably these patients like splenic function have also already before transplant some kind of thymic dysfunction. And this is an example of one of the patients, and as you can see, some families really are not expressed or just one. So, but this is very preliminary data. Julia Teixeira is looking on the, Julia is sitting there, immune recovery, so some data already from these patients, but also preliminary data. So as we know, I will not bore you again with this, but we know that this is a health problem in Brazil. That's why we are really very committed to this procedure. And we are very, very happy that still, after several years, we still could convince the government that it should be really a treatment that should be offered at the public system. And certainly this project helped the government to decide that this should be really approved. So we are really happy of this. It's certainly a work of a lot of people, and I really want to acknowledge all of them. Not only my fantastic medical doctors sitting here from the unit, the chief nurse, the psychologist, the physiotherapist, and stress Maria Carolina is sitting here also, responsible for the autoimmune program. It was not included that time, but it's also from this collaboration. The PhD student doing a fantastic work, the group from the EBMT, and Barbara Capelli put together all this data, and also my friends Eliane Gluckman and François Bernardin. Kellen Maubring is very active in the immunological part, and from the pharmaceutical science, and all the great people here from the Hemocentro. And these 2 collaborations, we are very happy to have them together in this protocol. Thank you.